Hello and greetings from UB. On behalf of the Office of Alumni Engagement and the School of Public Health and Health Professions, we are delighted you are able to join us for today's webinar presentation. My name is Christy Fields, and I'm the Director of Alumni Lifelong Engagement here at UB. I'm also joined by my wonderful colleague, Joy Rona, who will assist in monitoring any questions. We are both so grateful you are able to join us today, and I hope you and your family are staying well. It is my honor to welcome today's featured presenter, proud UB alumna and current Director of Graduate Studies for the MPH programs and Clinical Assistant Professor in the Department of Community Health and Health Behavior in the School of Public Health and Health Professions, Dr. Sarah Cercone Heavey. In today's session, Dr. Cercone Heavey will discuss how mental health conditions can affect anyone regardless of age, gender, race, or background, how the Erie County Suicide Fatality Review Team works collaboratively to address cases across our region, and how to recognize triggers and patterns in an unprecedented time in our society. We will leave some time during today's webinar for Q&A. If you have any questions at all during the presentation, go ahead and submit them through the GoToWebinar taskbar. There's a question section on your screen. Chat those to us at any time, and we'll make sure that we either save those for the conclusion of the presentation or even answer them as we go. And then in addition, we will be recording today's session, and we'll send you all a copy within the next 24 hours. So with that said, it's my pleasure to turn it over to our featured presenter, Dr. Sarah Cercone Heavey.
Thank you so much, Christy, and I'm thrilled to be here. I'm excited to talk about this. This is a real passion area for me. My background is really in psychiatric epidemiology, and then I did a T32 in suicide prevention. So I feel like this has been such a rewarding process to be a part of, and I'm excited to talk with all of you about it today. So we will first go through just some general data and information about suicide and how it is a public health issue. Typically, people don't think about it as being public healthy, so I like to just start out with kind of some general information, general trends, what we're looking at. And then I'm going to talk about suicide fatality review teams more in depth, including the work that Kim Rep has been doing in Oregon and how that has been translating into New York State's grant that is looking at this in a couple of different counties. And I'll talk specifically about what's going on in Erie County's team, how we're operating, kind of generally what we're doing, and some of the data that we have coming out of that review team. But first, I want to start with some acknowledgements because, to be honest, this is one of the most community-oriented projects I've ever been a part of. And it really, we wouldn't be where we are without Dr. Kim Rep's work in Oregon. So she's the person who really started this idea. I'll go into a little bit of the background. And then of course, Jessica Pirro and Janine Blank. Jessica is the CEO of Crisis Services, and Janine is with the Medical Examiner's Office, and they're our leadership team for the Erie County Fatality Review Group. And we would not be here without them. The work they've put into this has been immense. And then, of course, I want to acknowledge the Office of Mental Health Suicide Prevention Center and the New York State Health Foundation, both of which have funded this work in New York State and given us the opportunity to really see how this works and where this goes. So suicide is a public health issue. When we think about suicide, a lot of times people tend to talk about it in hushed tones, or they hear of a famous person who may have died by suicide. And I don't think that allows us to really recognize just how large of a problem this really is. So on this slide, you can actually see the leading causes of death for 2019. And you'll see that among every age group, suicide appears. And for all ages, suicide is actually the 10th leading cause of death in the United States. Now, you'll notice 2019 data is really what I'm relying on in this presentation. That's because there is about a 2-year lag. So we don't really have great data on 2020 or 2021 yet. Of course, that will be complicated by the COVID-19 pandemic. I will speculate a little bit about that in a few slides about what that may or may not be doing to the suicide rate in this country. But for all intents and purposes, 2019 is our best year of data, and that's what I'll be using in this presentation. So a few points to consider is men die by suicide almost 4 times more often than women. But women are nearly twice as likely to attempt suicide. And we also see a suicide rate higher for veterans than non-veteran groups. So those are a couple of groups that we think about as being particularly at risk. Veterans, given their military service and some of the things they may experience as a part of that, can be very challenging and require a lot of attention to work through. And so when we think about the suicide rate in the United States, you can see here the middle bluish, lightish bluish line here is overall in the United States. You can see the male rate is the dark blue line, and then the female rate's this lower line. You can see the rate has continued to essentially grow since 1999. So we've gone from about 10.5 deaths from suicide per 100,000 people to about 13.9 deaths per 100,000 people. And so seeing this trend increase, and seeing it for both men and women, is something that people working in this field are really concerned about, to see this rate continuing to increase rather than to plateau or to decrease, despite all of the efforts and programs that are being put in place, zero suicide grants, things like that. So it is something that we are looking at actively. And when we look at deaths by method, you can see that particularly for men, firearms is the most common method of death, and typically one of the more lethal means of death. So a gunshot can be a very lethal approach, whereas poisonings, there can be occasionally opportunities to reverse that poisoning. And so you just see the distribution, primarily firearms for men, a little more evenly distributed for women, firearms, suffocation, and then poisonings, all about a third of method of death. And when we look at those rates by age groups, we break out, just to orient you to the graph, rates is along the x-axis, on the left y-axis or female age range, and on the right y-axis, you're seeing male age range. And you can see that the rates for men tend to increase across age, whereas you see more so middle-aged women having the higher rate, and overall lower though for women than for men. But what's interesting about this is over the last 10, 20 years or so, we've really seen a changing pattern around the means of suicide for women. So typically poisoning, as you'll see in this dark navy line, was responsible for the most deaths from suicide. But since about 1999, this dashed firearm line has been increasing, and suffocation has also been increasing as well. And so we're actually quite puzzled by this. We're not really sure what could potentially be driving these differences. Potentially it's more access to firearms, so means restrictions a big component of trying to prevent suicide. So potentially it's more availability of firearms that's driving this. And then in terms of suffocation, we really don't have a great hypothesis for why this has almost quadrupled in rate over the last 20 years. But it is something we're keeping an eye on, and just something to bring up that we are seeing this changing pattern. And this is something we're seeing nationally. So this isn't local data, this is nationally we're seeing these differences. And so then when we look by race, ethnicity, so similar graph to one we looked at just shortly ago, female on the left side of the screen, male on the right side of the screen, but this time each group was broken up by race, ethnicity. So American Indians, Asian or Pacific Islanders, Black, white, and Hispanic individuals. And you can see overall the rates tend to be highest for white individuals and American Indian individuals. And this is something that we try to keep an eye on because of the disparity often in mental health services and mental health access for treatment. And particularly among American Indian communities, this is something that's really needs, well, we need work on this all the way across the board, but particularly for Indigenous peoples, access to mental health care is very difficult and challenging in a lot of those cases. But what I do want to take an opportunity to talk about is that there's a misclassification issue with suicide. So deaths from suicide are absolutely underestimated. We think it's somewhere between 10% and 30%. So the rates are likely higher, much higher in some cases. And people labeled with a suicide death are more likely to be white, middle-aged, and male, whereas undetermined is often used for African Americans, for example. And so there are a lot of factors around this that we're also trying to figure out. Obviously, stigma, including legal, religious, and political pressures, can be a challenge here. And preconceived notions, particularly ideas that people might come into labeling these kinds of deaths and how they get labeled, can also be an influence here. So know that even though we looked at those rates on the previous slide, it's probably not the full story. We're probably missing some information here. And there are groups working to improve this. Continuing education becomes very important for medical examiners and coroners, and various kind of geographical or political pressure might be also at play here. And so it'll be interesting to see where this goes going forward. And so when we think about suicidal behavior, often we think about deaths from suicide. And in the United States in 2019, there were 47,511 deaths from suicide. However, that's really only the tip of the iceberg. We also need to recognize there's hospitalizations from suicide attempts, required medical attention from suicide attempts, and then the overall number of attempts that may not even receive treatment or be addressed, but still happen. And so when you look at across the United States in 2019, there was almost 1.4 million suicide attempts. And then only, some of those received medical attention or were hospitalized as a result of that attempt. So this is a much bigger issue than just those who have died from suicide. There really is more to this than just thinking about those deaths. So what does the current data look like? This is usually a question I get asked when we start thinking about the impact of COVID-19 and how this may be changing or driving or addressing rates for suicide. And this is very provisional data. So the CDC has a number of really useful tools. This is part of their Whiskers. It's called Whiskers database, where we are able to look at provisional data. These aren't necessarily verified deaths in the same way that the kind of 2-year lag contributes to those really high quality data, but this at least gives us a snapshot. And this is actually fairly encouraging because what we're looking at here is across the x-axis on the bottom, we see time. And we're actually going from 2019 through to Q1 of 2020, which is when the COVID pandemic started to really gain momentum, through to 2020 Q4. So still about a year behind, but better than what we could use kind of from that big national data set that we have access to that has that lag. And we can see actually the rate is fairly stable. So I think this is actually encouraging. I think a lot of us were worried about a spike in deaths from suicide, particularly due to the isolation people were experiencing as a part of the pandemic, the inability to get high quality treatment or access treatment in many capacities, the switch to telemedicine for different kinds of appointments. And so to see that this is more of a flattened, even potentially slightly decreasing, I think it's 14.0 deaths in 2019 to 13.5 in 2020 Q4. So it's encouraging to see that this is flat and not a huge spike. But again, it's very much provisional data, and we'll really have to wait till that high quality data comes out, again, with that 2-year lag. So it'll take us a little bit to truly understand the impact of COVID. So before I start talking about the bright ideas coming out of Oregon, is there any questions, Christy, from the chat that I could clarify now?
Nothing as we speak right now, so if you want to keep going, but check in with me again in a few minutes.
Sounds good. Okay. So in Oregon, Dr. Kim Repp in 2012, so I've actually had the opportunity to meet with her and work with her, and she is just amazing. She has her PhD in microbiology and was doing food outbreak investigations, but she also has her MPH in epidemiology and biostatistics. So brought kind of a unique skill set and was working in the medical examiner's office. And in 2012, one of her colleagues came to her and said they're seeing this increase in suicide deaths. They're seeing it highest among the older white men, but they really don't understand what's going on. They really couldn't figure out what was happening. And so they said to Kim, figure this out. Can we look into this? Can we understand this? What can we do about this? And so Kim has talked about a sign in her office, and I don't speak Latin, so I'm not going to read the Latin version, but her sign says, "This is a place where the dead delight in helping the living." And so she really took some time to think about what could she do to get kind of better information about what was happening with this increase in suicide deaths. And she noted that the inherent challenges of this are very similar actually to the national data we were talking about. Oftentimes that data is very aggregated and really grouped, so it's hard to see what patterns might be happening among smaller, more subtle groups. And then the 2-year lag in data is also really a challenge, because if you want to do something today, you're depending on data from 2 years ago, and it can be very difficult to make changes in real time that could have a good impact. So what Kim decided to do was shadow a death investigator. So one of the local in Washington County, Oregon, she spent about a year shadowing a death investigator there to really get a sense of how their process worked. They actually got her a fun jacket that said epidemiologist on the back. And she really kind of dove into this process of how are death scenes investigated, particularly related to suicide deaths. And she came up with a couple of ideas that have really revolutionized this field. So her first idea was to develop something called a scrap tool, and we'll look at that in a few slides. So we'll talk about that a bit more in depth, but essentially an easy to record checklist that pulls in all of the relevant details and would allow the death investigator to collect more precise data more quickly. So addressing that time lag concern, and then also addressing having the right information from one death to the next death, and having that consistency in reporting became very useful. And then her second big idea was the fatality review team. So in the 1970s, there was a movement to have child fatality reviews. And so she modeled the suicide fatality review on those child fatality review teams. And the idea was to bring a variety of stakeholders to the table to better understand a given death. And the goal isn't to recognize, one agency's contribution over another, or to say, this could have, this hospital should have handled it this way, or this organization should have handled it that way, but really to use that information to develop system-level interventions that prevent future suicides. So two of the big, and frankly, I thought very surprising trends that came out of these first few years of the suicide fatality review team that Dr. Rep was leading were hotels and motels were a common location for deaths, for suicide deaths, and animal shelters, people in crisis, particularly people in crisis over financial concerns or eviction concerns, would often turn their pets over to an animal shelter first. And so what Kim was able to then do was to work with staff at hotels and motels. There were a few motels in particular that had relatively frequently experienced deaths from suicide in somebody who was there. And then the animal shelter staff as well, to offer trainings, to recognize someone in distress, and then to do kind of a direct call to the crisis line and have that person, if they were still kind of in that space, talk with someone on the crisis line. So it wasn't that they were training staff to be first responders, it was that they were training staff at both of these locations to recognize distress and then what to do when that was recognized. And this, and some of the other systems level interventions they started actually reduced the suicide rate in their county by more than 40%. So this is a huge drop in a really relatively short period of time. And if you remember to the beginning of the presentation, where we actually see overall suicide rates increasing across the United States, this is a particular victory. So this was really an exciting, out of the box thinking project that had a huge impact in only a few years at reducing the suicide rate in their county. So how did it get here? So Jay Crothers, Dr. Jay Crothers, who is in charge of the Office of Mental Health for New York State, got wind of this, and there were a couple of counties who were able to receive some grant funding to do this suicide fatality review team in their county, and Erie County is one of them. So basically, this is, I don't mean to oversimplify because everyone who's been working on this has been putting in a lot of work, but essentially we collect scrap data from every death from suicide, and then consent forms to participate in an individual case review are sent to the next of kin several months after death. And this is a very extensive consent form. It includes all of the agencies that are participating, and I'll show that in a moment who's included in those consents. And it's really meant in the spirit of understanding what systems level interventions that we could potentially be doing or implementing, or structural changes that could be happening to better address the rate of suicide. And so we have quarterly meetings where we review 1 to 3 cases more in depth, and then we also look at those scrap data. So this is a little, I actually took Kim's, Dr. Rep's scrap form, so the Suicide Consolidated Risk Assessment Profile, or SCRAP. Ours is electronic, so it doesn't look nearly as nice as this, but it goes through all these different risk factors related to suicide. And the death investigators, or in our case, the ME's office, completes one of these for every death from suicide. And it really starts to give us a better picture of what's going on. And I'll show some data from our scraps in aggregate in a few slides. So in our quarterly meetings, prior to our meeting, appropriate materials are made available to team members. This may include the death investigation report. It may include relevant information that has come up. And this is all quarterbacked by Jessica Piro at Crisis Services. So she is really taken this on and provided such amazing leadership for us to be so efficient in our process here that honestly, she's really helping us kind of do all of these things as a part of this project. And so in our meetings, generally what we do is we look at our aggregate scrap data. That's really where I come in. I talk about the data, take a look at some different trends, different things that we're seeing. And then for each case, we go in depth into that case, and we go through all of the case information. We ask questions, we ask for clarifications. Usually it starts with the ME's office taking us through the investigation, and then any relevant organizations who might be able to contribute additional information are able to do so. We talk through the investigation, we discuss what services the person may have been engaged with or may have benefited from that weren't necessarily there. We talk about different risk and protective factors that person may have had. And then we think about what are those system level improvements? What can we be doing from a broad overall scale that would allow us to potentially prevent deaths from suicide in that kind of way in the future? And then we go through any final steps that might exist. So anything that might be lingering or we might have questions about, and we really think through how do we either address or adjust or change things going forward. And I should also acknowledge we take confidentiality very, very seriously with these meetings. For each meeting, we sign an extensive form outlining why it's important to keep things confidential, why this is information that we would not keep on computers after it's been used. We're always, disposing appropriately of any documents that may have been shared, and the anonymity of the person to the extent possible. We're also, making sure that we're engaging in these conversations in private office spaces, not places that could be overheard. So there is a great deal of effort made to protect the confidentiality while also doing the work necessary to protect the public's health from suicide deaths. So lots of places on this slide, and I don't mean it to be overwhelming, but I do want it to kind of convey just how much of a community effort this is. So we have representatives from all of the organizations listed here, including obviously the medical examiner's office, we have NAMIs involved, we've got ECMC involved, all sorts of stakeholders come to this meeting together to bring their expertise and to bring in ideas and excitement and how can we start to address this. And it's really one of the most rewarding meetings of my quarter, to be completely honest, because everybody is so devoted to shifting the rates of suicide and what we can do as a community to do that. And so, you know, each of these organizations plays such a vital role in thinking about ideas, bringing new information to the table, and then, you know, facilitating different efforts that we then try to change some of those structural issues. So let's look at the data. This is really my wheelhouse with the fatality review team. I love data. I can't help it. And so I'm just going to take us through some of our data so you can get a sense of what we're looking at in Erie County. Obviously, this is all an aggregate. Obviously, this is all anonymized. You know, I took the appropriate precautions prior to this, but just want to give you a sense that since the suicide fatality review team started, we've collected data on 162 scrap forms, all Erie County. We're seeing an average age of around 45, though we do have cases less than 20 years old and older than 80 years old. We're seeing primarily male individuals and generally people who are identifying as heterosexual or straight, or there's a large chunk of people we don't know that information for, so we don't guess, we just indicate that we don't know. In terms of interacting with healthcare, so the majority of individuals have had a healthcare interaction within the year prior to death. So of those that we know, most have had at least one healthcare interaction in the year prior to their death from suicide. And so that's something that tells us, hey, there could have been potentially something, an intervention that might have been possible in that year prior, well, at that healthcare provider's office. And so going right through the scrap, to be honest, each of these are questions on the scrap. Blue indicates a yes or an affirmative, having that contributing factor. Orange is unknown, and the light blue is no. So you can see of contributing factors, those things present in the months or years prior to someone's death from suicide. You can see physical health problems and family relationship stress both being more common. And then social isolation is something that has actually started to increase significantly as we've started to move into the COVID pandemic time. So once we have some more data on that, I intend to look at it a little bit more in depth. Right now, it's still a little bit early to really draw conclusions on that, but it is something we're watching and something we're thinking about. Some other contributory factors, these are less common. But eviction, job problems, and financial problems or instability often come up, and also potentially having a criminal legal problem. But again, overall, you'll see that only about 20 or so individuals out of the 162 that we've looked at had those experiences. So these are relatively uncommon risk factors for someone. When we think about lifetime history, we know, having experienced self-directed violence, having suicidal thoughts or plans, or a previous suicide attempt are all associated with a subsequent suicide attempt. And so those are things we are looking at. You can see a relatively high number of individuals have those experiences, as well as having experienced mental health or substance use treatment in their lifetime. Perhaps unexpectedly, we actually see the history of abuse. So this is the last bar on this graph here, abuse. That's actually a lot lower than I think a lot of us thought it was going to be going into this. And that could be an anomaly because abuse can be a very difficult thing to assess if you're not able to talk directly with the person. And all of this is from interviews with families, reviewing health records when available. So it is possible this is actually truly higher, but we're just not able to capture that data. And it is a very broad definition of abuse. I do want to acknowledge that it includes physical, sexual, or psychological abuse, as well as neglect or exposure to violent environments. So it is a very large concept and would be more difficult, a more difficult construct to really tease apart. So in the past 30 days, from what, again, we were able to kind of discern from the interviews and the scrap form, suicidal thoughts, intents, being the victim of intimate partner violence, or being the perpetrator of intimate partner violence, all risk factors, of course, for death from suicide, but relatively, again, low prevalence of these across the cases that we have scrap data for. And then at time of death. So this set of questions is really, when the person died from suicide, were any of these things present or happening? So were they using substances? Were they using alcohol? Were they currently engaged in mental health or substance use treatment? Did they have a mental health diagnosis? Or did they have depressed mood? And as you'd probably expect, these were all fairly common. So it's something that often comes up, having a mental health diagnosis and the subsequent suicide makes, it makes sense with what we know about suicide. And then, of course, depressed mood being a part of that as well. So finally, we look at whether the individual experienced a crisis in the past 2 weeks. So we know experiencing a crisis, and I'll talk about different kinds of crises in a moment, but we know that can be a real trigger for somebody, particularly if they're dealing with a mental health challenge, and that crisis can sometimes be a contributing factor to someone dying from suicide. And so this is something we look at very in depth, and we see that only about a third of those cases did experience a definitive crisis. Of course, there's some we're unsure about, and again, given the nature of death investigation, it can be very difficult to truly get to this. But this is a lower number than I think a lot of us might have assumed going into this work, that typically we'd think there would be more crises that somebody might have experienced, but overall only about a third of this sample did experience a crisis. And so you can see the crises indicated here. Most common, family relationship problems, but of course, criminal problems, job problems, financial instability, and physical health problems were also common. But again, only about 30% of the sample experienced this. So taken together, what are the trends we're seeing in our Erie County scrap data? Well, we're seeing majority male, middle-aged, and heterosexual, which is on track with those national trends we talked about at the start. We're also seeing that they've had a healthcare interaction within the past 30 days, but generally distributed over a year for those that we have that data on. Typically, the most common contributing factors we see are family relationship stress, physical health problems, and social isolation. And then that lifetime history of mental health or substance use treatment, as well as having suicidal thoughts, plans, or attempts in their lifetimes. And then at time of death, it was common to see mental health problems, depressed mood, as well as alcohol or other substance use problems. And most did not experience a crisis in those 2 weeks prior to death. So of those who did, we have those common crises listed there, but most were not experiencing crisis. And so that really kind of shifts how we think about addressing this from a systematic level and thinking about what longer term structural or community level factors can we address that could potentially help support somebody in these experiences. And so one new thing that we've actually started looking at is the geographic distribution of these deaths. So we have kind of looked at them by different type of, by different means. of death, and we can see them kind of throughout the city. We don't have a big enough sample to do a true GIS analysis where we look for statistically significant clusters, but it is something that we are working on and we've just started to dive into. So I just wanted to share that this is something we're also working on, and we look forward to seeing where this goes as time goes on. So before I get into any kind of structural changes, other things that we're talking about, Christy, were there any other questions that may have come up that I could clarify?
Yeah, actually, there are some questions that have come in, so we'll take a few here, and then we can kind of maybe save some for later as well. This next question here that was submitted, how many annual suicide deaths occur in Erie County?
So Erie County's actually been doing a really impressive job outside of the suicide fatality review process. I believe there were 100, around 100 in the most previous year. So we've actually been declining in deaths over the past 4 or 5 years. And a lot of that work is really due to the partnership between the medical examiner's office and crisis services, where they really partner to do different interventions around preventing suicide that have been very effective.
Excellent. And this next question here, how are you determining gender identity?
So that is a question that's asked to next of kin. And so it's arguably, yes, it's not a perfect method because we're not able to ask the decedent what their gender identity is, but it's kind of the best that we can do. So we would ask next of kin as part of the death investigation. And then it also may come up if the person had a healthcare interaction and perhaps it had been asked at that, they're able to verify it that way.
Okay, excellent. And we'll do one more here and then I'll let you keep going. When you showed that slide of all the different organizations that are involved, this next question says, the visual and performing arts on the committee, why was this added?
So the one of the high-ranking members of that school is very attuned to mental health, and so we wanted to have somebody who is within the Buffalo schools. And this particular individual is again very passionate about mental health and is serving on this to give us the perspective of somebody who's worked in schools and somebody who has that background working with youth to bring to this discussion. And she's been actually just wonderful to work with, and she brings a different perspective than a lot of us who are used to thinking about things like for adults. And so we start to think about that rate of about 20 youth who've died by suicide. She's really helpful in kind of presenting a different attitude, so we can kind of think about things from the mind of youth rather than from the mindset of an adult. And so that is really, she's representing the Buffalo schools.
Thank you so much, Sarah. We'll continue on and then we'll come back to a few more.
Sounds good. So as a part of this review team, so a lot of what I've just talked about has been quantitative data analysis, where we can, get into the bean counting of things and say we've had this many check boxes marked yes. We also, as we're going through each case review, we actually do a more qualitative approach where we take narrative notes and then we look for themes in those notes. And I find it just a convenient way to look at those themes with this Wordle here. So you've got the kind of different themes that have come up from the case reviews that we've gone through, and you can see history of psychiatric treatment, depression, male, family relationship stress, all being themes that have come up for multiple cases. And so that is consistent with our scrap data. It probably is sounding pretty familiar risk factors to you by this point in the presentation. But it's helpful for us to be thinking about this, not just from a numbers perspective, but from a thematic perspective. And so we use these to help us really think about what areas might we want to work on or address or develop in different ways that could help us prevent suicide going forward in the county. And so I'm going to give just a couple of system levels interventions that have come up as potential examples of things that we'd like to work on. one of which is including training for child protective services, particularly working on those CPS workers. It's a very difficult job, and dealing with targets of child abuse and neglect is very challenging. And those families who might be engaged in this process can also be just extremely stressed because of those experiences. And so thinking about what trainings we might be able to provide for CPS workers or police investigators working with CPS, or other ways to think about how we can support both parties in this would be one potential systems level intervention that we are working on. And there is someone who's designated full-time at ECMC in their CPEP, their emergency psychiatric unit, to work with investigations for those new calls and act as a liaison for those who are at ECMC. So it is something that is ongoing and something that we're working on. One of the other system levels interventions that has come up is changes, either physical or structural changes to the Buffalo Skyway. And this is one that came up very early, and it's a tough structure because of the design of it, the design itself. So anybody who's driven over the Skyway knows it's challenging. And we got really excited when they announced that they were going to pull down the Skyway. And we thought, wow, that's, we just thought about this and it happened. And unfortunately, it seems to be on hold at this point. So we're a little disappointed to see that plan has been paused. But now we're revisiting some of the ideas, including using billboards or painting and adding numbers or signs to the Skyway to help encourage people who may be experiencing a crisis or experiencing some suicidal ideation to call the crisis line, for example, or to somehow other forms to engage with treatment, because of that structure can be particularly difficult. And then we've also seen loss of health insurance being a concern for some cases. And so, perhaps more education with either, if there's divorce attorneys involved or if there's HR involved, how do we think about how we bridge somebody with health insurance? And then in those situations that are triggering loss of health insurance, could they use the health exchange? Are there ways for this to come up in divorce proceedings or in separation from jobs? We've seen a couple of these cases come up where this has been a trigger for someone, and how do we think about making sure they understand there are other insurance options for people, and it's not necessarily as a crisis in the sense we can address it and overcome it. So those are just 3. We actually have a list of 18 so far, so I'm not going to take everyone into those, but hopefully we have some time for some questions and discussion. I'm happy to talk further about any of these things that have come up, and I appreciate your time. Thank you for listening to me talk about such a passion project, and I appreciate the opportunity to be here.
Thank you so much, Dr. Cercone Heavey. This has been outstanding, the information that you've shared. Really appreciate you taking the time to be with us. We do have a few more questions that have come in, so we'll continue just some discussion here over the next few minutes. Is there any coordination with Niagara County or the City of Niagara Falls?
Not at this point. So the Erie County Fatality Review Team is linked to a grant that's been given from New York State. And so I can actually I'll pull up the acknowledgements page just to highlight that grant, because it's such an innovative grant. And so they identified 4 counties in New York State that would have higher rates of suicide and that needed addressing. And so that's really part of how Erie County came to be part of this. And that's really where this has come from. So at this point, there's not work being done with Niagara County. Isn't to say that it isn't something possible in the future, but just the parameters of this grant were to focus in on Erie County.
Super. And the next question I have here, what does the data indicate about connection between the rise of opiate addiction and national suicide? Is it demographic specific?
So that is such a great question, and that is something that I think about all the time, because the other half of my research life is on opioids. So I'm constantly thinking about this difference between deaths from suicide what's often labeled an accidental or unintentional opioid overdose, and how much blur there might be between those two phenomena. And I don't have a great estimate. There's not a good number I can give you, but there are a lot of scholars working on this, and we believe that it's a much higher overlap than we might really acknowledge. And I like to highlight, so there's a researcher named Ian Rocket who kind of came up with this concept of the idea that using opioids is essentially a self-harm behavior. So maybe it's time for us to stop thinking about this as such a binary difference and really start thinking about these kind of self-harm behaviors as a whole, and not get tied into, is it a suicide or is it an accidental overdose? And I think there's a lot of merit to that argument. Dr. Nora Volkov, who is the head of NIDA, the National Institute on Drug Abuse, has written extensively about this issue as well. And so this, I think, is one of the really interesting overlaps, and we're still trying to figure it out. So stay tuned, because I think there's more to come in the next couple of years around it.
Sure, absolutely. Sarah, this next question we have here, can you suggest any online communities, etc., for someone who doesn't work in these professions, but generally really wants to learn and help?
Yes, so crisis services locally, they do so many different events and initiatives and trainings and outreach events. And so I think if you're looking for a local option, crisis services is certainly one to consider. There's also NAMI, which we have a Buffalo chapter for, and they do a lot of advocacy work and trainings and events as well. And then when we're thinking nationally, there's actually the American Foundation for Suicide Prevention. And so they have a local chapter, but they're also a national organization, and they have extensive resources, especially around some of the data, some of the things we've talked about, different programs that seem to work. And so I think they would be a great national resource.
Thank you for sharing that. And Sarah, this next question, just somebody who's not in the Buffalo area, can you maybe expand or say a little bit more about the Skyway and that initiative you were talking about?
Yes, so the Skyway, there seems to be something of a love-hate relationship on the Skyway in Buffalo. It's very convenient for getting to the southern part of the city, but it's a bridge that's very, very high. And over the last 20 years, there have been a number of people who have died from going over the Skyway, so jumping from a high height and dying from that fall. And so it's a very structurally, it's a very difficult place, and it's kind of akin to actually the Golden Gate Bridge in California. And San Francisco has a similar problem where people typically use that if they're looking to die by suicide by falling from a height, because it's very high, and there's a very small chance of if any, of survival. So the structure of the Skyway makes it such that it's an accessible place that this could happen. And so a lot of ideas are happening around how do we either put crisis services phone information there. What they actually did in San Francisco is they actually put a phone on that directly links to a crisis services line. That won't work because there really isn't space for that on the Skyway. It's really just a couple of lanes wide and just for cars. It's not for pedestrians. So maybe using a billboard, and there's some different kind of structural things. But that's a great point. It's good to know we have people outside of the Buffalo area. I'm sorry for kind of skipping over that.
Fantastic. Thank you so much, Sarah. It looks like those are all the questions that have come in at this time, and I know we're getting close to the top of the hour. So I really just want to thank Dr. Cercone Heavey for spending time with us today, for sharing her expertise with us. We are very grateful. A reminder, we recorded this session, so if you want to take a look at it again, you're going to receive it in your email tomorrow. So make sure you check your inbox for that, and then you can go back and rewatch and maybe digest some additional information too at your leisure. So be sure to do that over the coming days once you receive this tomorrow. Also too, just wanted to share our webinar series is continue next week. We have two presentations. We have one We're going to be joined by two friends of UB, Tyler Shaw, Public Health Director for the Allegheny County Department of Health, and Paul Pettit, Public Health Director of the Genesee and Orleans County Health Departments. They're going to answer some questions about leading rural public health departments through some of the most difficult times in their history. So be sure to register for that. We'll make sure that's in tomorrow's email. As well, if you're a sports fan, we're leading into the Super Bowl weekend. We do have a UB alumnus who's going to join us and talk about how football is becoming America's #1 spectator sport. So whether you like sports or you want to hear more about public health in those rural communities during this time in history, be sure to register for those in the next email that you see coming through tomorrow. Also, too, we have all of our webinars up on our website. This will be up in our webinar library as well in the next day or so you can access it from our webinar library as well. With that said, I'm going to turn it back over to Dr. Cercone Heavey just for any closing remarks on her side or any advice or resources she'd like to leave with you before we do conclude today's presentation.
Thank you so much for having me, Christy. It's been such a pleasure to talk with everyone. And I, in thinking about suicide, hopefully this was a more hopeful presentation about the exciting work that's happening to reduce the rate of suicide. But, I think I would be remiss without talking about that these, are unprecedented times, and there is support for people to help kind of with some of the mental challenges that are coming with being in, going on multiple years of a pandemic and just all of the challenges that's a part of. I can assure you that nobody is alone in that, and there are support and resources out there. Crisis Services locally is a particularly wonderful organization who can really help connect people with the support that they need. And so, when that's something that comes up for people, please reach out, because it really is something we work on to change, and we're really looking to, I'd love to get to zero suicide in my lifetime. So it's something we're all working on very hard, and the support and resources are there for people if they need them.
Great, and we're so thankful for the work that you are doing in this field and the time you're spending in those quarterly meetings. We're so thankful. So as a proud member of the UB community, thank you. We hope you all enjoyed today's presentation. You took away some key points, some learning, some education that you can take back with you as well. Thank you all for joining us. Take care, stay well, and enjoy the rest of your day. Bye-bye.